This is Keith Hutchison, and I'm going to be kicking off our presentation today, which it will cover navigating the 24 reimbursement landscape. I want to present our speakers real quick here. And as you can see, I'm Keith Hutchison, a partner in reimbursement services. I have with me today David Gregory, who's a partner in healthcare consulting. He has with him Keith Needham, who's a senior manager in our healthcare consulting. And we also have Brian Restivo, who is not a senior manager, but a director in our reimbursement services. So going on to, we will each cover a certain area today. We'll try to make the handoffs as smooth as possible. One thing to remember, if you do ask a question and you don't put your name, and we don't have time to answer questions, we won't be able to respond to you. So if you really want us to respond, put your name. Next we'll cover our objectives, which are, we're going to cover obviously the inpatient PPS final rule for 24. Keith, next slide there. Oh yeah, you're on the right one, sorry. The DRG service lines, value-based care, new technology changes, that'll be covered by David and Keith. And then we have some 24 outpatient proposed rule changes that we thought were important to get to you guys today as well. The agenda really is basically the individual topics we'll be talking about in those areas. I don't really see a need to go through each one of those individually. So let's go ahead and get this kicked off with, first we're going to talk about the inpatient rule. And if we can go to the next slide, this is the market basket increase table. And I'd like to go back to 23 first to start kind of as a base and say, okay, in 23, we had a rate increase, market basket rate increase of 4.1% that was adjusted by productivity down to 3.8%. So that kind of sets the tone. The 2024 proposed was 3.1% that was adjusted to 2.8 for productivity. The final rule here slightly higher by 3.3 with a 2% reduction down to 3.1. So not much change from proposed to final, but lower than 23. So that's where we stand from a market basket before budget neutrality. Budget neutrality is really big this year. Last year in 23, it took it, let's say, approximately from 3.8 to 3.2. If we go forward to the next slide, then we have some of the, well, this one here shows you, if you go out and you try to look between the two table ones and say, how come that doesn't come out to be what you just said of 3.1%, it's because of budget neutrality. So budget neutrality takes us down from 3.1% to 1.9% if you're under a wage index of 1 and you're a meaningful user. So you can see you only really end up with a 1.9% adjustment to the base rate. So then what are some of those budget neutrality adjustments? Because the list continues to grow and grow. We have on slide 8, we have the first couple are DRG factors, DRG and capital factors. Really not much impact and not much change between proposed and final. Then you have a wage index budget neutrality changed a tad bit. The biggest change was the next one, which is the reclassification budget neutrality, which was proposed at 0.98, ends up being down to 97, which is an almost hit 1% additional reduction, which is probably one of the bigger impacts of bringing that market basket rate from 3.1 to 1.9. There's a few others. The rural floor is not in this because the rural floor adjustments right into the wage index that Brian will talk about later. But we do have a low wage index policy adjustment, a capital adjustment, and a rural demonstration adjustment. So anything that new that pops out, you're going to get some kind of budget neutrality adjustment for. So you can see what all these things do to the base rate. Some more items that impact you in a negative manner are the outlier update, which went up big in 23, a little smaller in 24, but these are the proposed changes from CMS that they feel are needed to keep the outlier percentage where it needs to be as a percentage of your overall payment. One thing really to remember in your outliers, if rate increases and so forth are going up, we always have to remember that annual outlier reconciliation. So if you have more than 500,000 in outliers and you experience a 10% change in your cost to charge ratio because costs went down or your rates went up, then there's going to be a reconciliation, and it's going to be in your cost report, but it could be something that you end up paying back. So you got to pay attention to that. So from there, we go into the next big reduction from that rates that we just talked about this year, and that's going to be in uncompensated care, which kind of slid in on the end here. We start out really with nothing changed. We're using 18, 19, and 20 as 10 factors. They're going to start a 3-year average for the fluctuations. Merged hospitals will be done on the surviving hospitals cost report data, because at that time both will be together. The bigger message really is on the next slide. One thing to remember here again, and this becomes a cost report issue and almost a reconciliation issue, and that is in the final payment. You have to remember that you're not going to get paid exactly what is in, well, you are going to get paid on what's in that table, but you can be a winner or loser in the settlement. In other words, if your discharges come out higher than what are in the tables for the average 21 and 22, your MAC will pay you the amount per claim out there, non-case mix adjusted. So if you came out with 100 more discharges, then you'll get paid for 100 more and you'll owe that back. Conversely, if your discharges are lower on your cost report than what it says you're going to get, then you will get that in a receivable on your cost report. So even though this is a payment, it's not case mix adjusted, it does tie into your cost report payable receivable. Then the next slides really get into 13 and 14, and I'm showing you the slide that was in our proposed rule presentation for 24 that showed that this year would be $161 million cut. And we're showing you that slide because some of your factor 2 items really changed there. The factor for 23 and 24, remember those 9.3, 9.2, and the weighted for uninsured at 9.2. We go forward to 24 slide, final, and you can see that the factor 2 items changed. It's a little small to read there. but it ends up being a $936 million reduction. And that $936 million reduction is a result that the actuarials changes, according to CMS, to factor 2 percentages, which you can see are now 7.7, 8.5, and 8.3. So that reduction reduced the overall factor 2, which comes out with a lower uncompensated care pool, which impacts all of you. The average reduction is probably somewhere in the $400,000 per provider that was receiving uncompensated care. There will be some new winners, but that would be because of either methodology or you're new into uncompensated care or some change that an individual hospital made. But the result of this additional cut in the pool really hits everyone. So you can see that the reductions start to add up. There's also a new technology reduction that our guys will talk about, new technology. So by the time you get into some of the bigger payment adjustments, you've really cut that top number down to about nothing. So that's my good message for the day. At this point, I'm going to turn it over to David Gregory to, first, we've got a polling question, and then we'll turn it over to David Gregory. So the polling question is, do you know your individual? We said the average is around 400,000, but some are much, much bigger, and some are not so big. So it's something to look at in planning into your budget, and hopefully you either know it or you'll find out soon, or your hospital association sent it to you. So answer that, and I think we go ahead and move on, guys?
Yeah.
And show the results later. So I will kick it off to David.
Yeah, I think we will share the results with the group as soon as we've got them. We'll keep moving here, and those results should come up here pretty quickly, as long as we get over 80% of you to respond to those. And remember, you need to respond for CPE. I'm gonna kick it over to Keith Needham here in a moment, but we are going to talk importantly about MSDRG changes and some impact analysis we did. Ordinarily, I say that Keith is a tough act to follow, but man, there's nowhere to go but up after that message, Keith. But all kidding aside, we totally understand the fact that hospitals had literally their worst year ever as a group, as a cohort in 22 for lots of different reasons. Inflation, elective care was still spotty, et cetera, right? So we understand all of the challenges, and this is not good news that a 2 to 3% bump that almost, as Keith just said, goes away when you look at all the other adjustments, makes for a tough road to hoe for sure. And we've got a couple of levers that can be pulled, to help you kind of mitigate, some of this news. Keith is going to talk about some value-based care programs that are back in play, which may or may not be good news to you, depending upon whether you're, actively trying to go get those dollars or not. But right there are a couple of levers to pull that we'll talk about. But I'll just say that this news really puts pressure on your CMI, to continue to increase your CMI, to continue to improve your clinical documentation, and to continue to reduce your length of stay, right? Those initiatives that have been around for a long, long time, just take on renewed importance, right? As we deliver this news, which is not great, as Keith just indicated. So I think we do have the polling results before I turn it over to you, Keith. It looks like it's kind of hard to look at it all in one spot, but 17% said that the impact would be negative, and 7% said yes, but the hospital receives a hospital-specific payment. So that was 7% of you, and then 5%, and smaller increments see yes, but our uncompensated care increased. So that's 5% of you. 4% said no, my hospital doesn't receive uncompensated care, and then 2/3 of you said you don't know. And so certainly that's why you're on this call, and we're more than happy to help get you guys up to speed. But that is notable. The 2/3 of you said you weren't sure what the impact was. So Keith, at this point, I'll turn it over to you, and I think you're controlling the slide, so you can control your own destiny there.
Great, thanks, David. Piling off of some of the comments that we've heard thus far, we continue to kind of review the overall impacts from fiscal year 2023 to fiscal year 2024. So what we did is we created a case mix index adjusted comparison here across several of the slides that we're going to discuss. And what you'll see here in the first box is we only saw a very nominal or minimal change across the DRG weights with about a 0.3% increase from fiscal year 23 to fiscal year 24. We did leverage the same utilization, so kind of ensuring that the case mix adjustment does not impact that figure. And then dropping down further, across the major disease categories, we did notice 13 were impacted positively, and the remaining 13 were impacted negatively, excluding newborn and neonates. So diving into this a little bit deeper, we'll notice that the quote-unquote winners saw some substantial increases. A few notable ones here are MDC 22, 19, as well as pre-MDCs, as well as 10, seeing increases all the way up into the 15% range, going down into about a 3% increase. And then on the flip side, thinking about those MDCs that did not see a positive increase and in turn saw a reduction in the DRG weights assigned to them, the major ones being MDC 23, which are factors influencing health status, as well as a couple others, again, about a 1% decrease for the circulatory system, ear, nose, mouth, and throat. So diving in a little deeper around some of the winners. So obviously Burns was impacted greatly by the increase in the DRG weights from fiscal year 2023 to fiscal year 2024 with the DRG series 927 and 928 seeing almost a 40% increase or DRG weight impact, and then a 12% increase for DRG 928. And then going further into MDC 19 around mental diseases and disorders, we continue to see, CMS review and modify kind of the support and care related to mental diseases and disorders, as shown through obviously the positive impacts here from a DRG weight perspective, as well as some of the other quality metrics that are starting to, get incorporated as well. So seeing some positive DRG weight impacts across, 17% as well as 16% respectively. Here, diving into the quote-unquote losers, aftercare did take a big hit as well as rehabilitation, seeing about a range from 10% to 13% decrease. And this is focused around, patients that are getting care for specific injuries of interest, and as well as things like poisoning, right? And then obviously rehabilitation as well saw a 10% decrease. Thinking about the David's comments as well as changes to IPPS payment rates, right? So the hospital readmission reduction program, as well as hospital acquired conditions and VBP are back in full swing. Individually, these may not kind of move the needle from a hospital perspective, but when we think about all three of these programs combined, it could have a potential negative impact of up to 5 to 6%. So ensuring, the review process of these and taking into consideration the hospital readmission reduction program, the final impact won't necessarily be readily available until fall 2023. And that's to allow hospitals time to review and correct some of those calculations. And then similarly on the VBP side, the final impacts won't necessarily be readily available until fall 2023 as well. So here what we're doing is looking into the overall financial impact across each of the MDCs. So leveraging 2021 utilization as well as the market basket adjustments and modifications to the DRG weights. We are seeing 2 up to 4% increases from fiscal year 2023 to final rule 2024. While it does seem positive, again, taking into consideration some of the increased inflation and costs that have been consumed by providers over the past couple of fiscal years, it still is somewhat lacking in allowing these hospitals to meet the demand and the increasing cost components of caring for these patients. New technology add-on payments. So there have been an increase in submissions for these new technology add-on payments, year over year. There is a sunsetting process every year for these products that get approval through this initiative. So there is a estimated decrease of $460 million in fiscal year 2024. But this most recent final year fiscal final rule, we saw the largest volume of new technology add-on payment submissions to date, with 11 being accepted into the program. So why is this important, right? One being there's incremental reimbursement for the use of these products, right? So understanding what those products are and how they are incrementally reimbursed, and potentially identifying a pathway for use across the facilities to garner some of that positive incremental reimbursement. Polling question number 2.
Yeah, Keith, I can take this one. So thanks, by the way. So I think it's a savvy group. So I know that the commercial contracts get impacted by what we're talking about here today, because a lot of commercial contracts say, hey, we're just going to use a multiple of the Medicare platform, and so wanted to just get a read on the audience in terms of, do you know what the impact of at least the inpatient side of things has on your commercial managed care agreements? We just want to draw your attention to the fact that this is not just contained to Medicare and to your federal business, but it also could, and likely does, impact your commercial business too. And that's where you're trying to make up the difference, right? We all know that Medicare doesn't pay, your full cost, and hasn't for 20 years. But your commercial contracts are supposed to make up that difference, right? And so so if you could just respond to this polling question, yes, no, or our hospital association has helped us model it, or not applicable, we will get those results over to you here momentarily. But I at this stage, I think we'll advance the slide and ask Brian to take over from here, right, Brian?
Thanks, David. I appreciate it. So next up, I'm going to talk briefly about some medical education updates here in the final rule. There wasn't too much activity going on in this rule here. If we move on to the next slide here, we talk a little bit about the nursing allied health program, which falls under the medical education umbrella. In here, Medicare made a couple clarifications out there for those that are impacted. There was legislation that lifted the $60 million cap to these nursing allied health payments, which was a significant amount of money for a lot of hospitals, especially those that operate in nursing schools. And it was a 9-year period in which they waived this cap from 2010 through 2019. But there's a few caveats that Medicare did clarify in the final rule. One being that in order to obtain the relief under these paybacks to the hospitals, is that program had to be operating as of December 29th, 2022. So if you ultimately close your programs at some point in time, you may not get that funding back per program for those. The other caveat they mentioned was that they're only going to go back and apply this to any course report within the 3-year reopening period. So a lot of these years are old, 2010 through 2015. They're probably all settled, maybe outside of that 3-year window. You may have some open appeals with some law firms fighting for that. So you should still pursue those appeals and talk to your attorneys about those older years that are outside the 3-year window. And then moving forward, Medicare has reverted back to the $60 million cap. So this was not a permanent relief to hospitals. Starting in 2020 and moving forward, the cap is back in place and reducing those payments. So just to kind of flip back before I move on to the next slide, the polling results showed that that 17% do understand what the impact is on their commercial managed care contracts. About 37% have declared that they don't know what the impact is. So again, as David mentioned, we want to make sure that you guys are taking a look at your commercial contracts when these Medicare rules come out to see what downstream impact you may have. And we're also here to help get through some of that. David's group does a lot of good work around the managed care contracts and understanding some of these downflow impacts from Medicare down to your commercial payers, including the Medicare managed care product lines as well. Moving on, I'm going to talk about besides the uncompensated care pool changes that Keith spoke about, the other major disruptor we saw a little bit in this final rule was changes to the Medicare wage index. Year over year, we saw a few things that are going on is that we saw the largest increase in the average hourly wage year over year. It came in at about 5.4% over the prior year. A lot of that was due to higher pay for nursing staff, contract labor, and all those. There was some comments and pushback that Medicare would normalize the data for some of those outlying spends from hospitals, but CMS determined that there was no such adjustment necessary. So we're starting to see the influx of all the high cost salary expense that you guys incurred starting really in federal fiscal year 2020, which is really the first kind of year that COVID impacted your salary expenses moving forward. And there's always a large lag and delay between the time you spend on that salary cost and when it flows over to the wage index. So we'll probably see an uptick here in the next year or two as well. But what we saw across the board was there was 228 urban areas that had an increase in their wage index and 26 rural areas that had an increase. Again, since everything is budget neutral, there are losers here. And at a macro level, if you're not keeping pace with that national average of the 5.4%, you're going to have a decrease in your wage index year over year. If your rates are going up, including benefits above the 5.4, that's where you're going to have your wage index increase. And it's not always hospital specific. You got to look to your peers and your competitors in your market of how you're overall comparing to the national wage there. So next slide, I'll talk about some of the policy updates that we've seen the past few years that are still in there. They are continuing to use the 25th percentile adjustment, meaning that if you're in the lowest 25th percentile, you're going to have an upward adjustment. The actual factor there increased from the prior year, and that's being driven by the overall change in average wage. This policy is being challenged in the courts. Medicare acknowledges that, but states that they're still going to pursue this lowest quartile adjustment moving forward unless the courts say otherwise in their appeal. And they have come out and said that they're not quite sure how long they'll keep this in effect, whether it becomes permanent or at some point in time will sunset. So this helps out those hospitals that are in the lowest quartile. And again, everything is budget neutral. So the hospitals that are at the top tier are negatively impacted here with the budget neutrality factors Keith spoke about earlier. So on the next slide here, I'm going to talk about really the biggest change that we saw here that affects a lot of hospitals is how Medicare computes the rural floor. So there are hold harmless provisions that prevents urban hospitals from being paid less than any rural CBSA market within their state. What Medicare changed for this final rule, as we saw in the proposed rule, was that those hospitals that are urban hospitals that have reclassified to be rural under Section 412, 103, and when there's hundreds of these hospitals out there, Um, your hospital wages for those reclassified hospitals are now going to be included in the rural floor calculations. So your wages will be counted twice. So we counted in your state's rural area as well as your home CBSA market. And what this did was drive up the rural floor in a lot of states. So a few states went down, which I'll talk about in a little bit. But what happened here was there's in 24 there'll be 646 hospitals that will receive the rural floor in 24, and compare that to last year, there was only 275 hospitals. So there is an additional benefit for those 400 plus hospitals there that got an increase or a positive impact there. What we saw though is because there was such a large pickup of hospitals that qualified for this, the budget neutrality factor increased significantly over the prior year. So essentially what Medicare is doing is they're taking a 2% reduction off everybody's wage index of what it should have been because of this rule. And compared to the prior year, it was a little less than 1%. So again, if you would have been at a 1.0 wage index with this reduction factor, you're sitting about around 98%. So keep that in mind, when you go through some of these changes to see how it impacts your facility. So on the next slide, I'll talk about some of the winners from the rural floor. Again, compared to the old method and compared to the prior year, what we've seen is the states that have the most reclassified hospitals have a big driver here. New York, Arizona, Connecticut, California, even Pennsylvania. All those rural floors increased more than 15% between the old method and the new method. And you can kind of see here, I won't go line by line, but the significant increase of what the rural floor is between 23 and 24. If you look at Pennsylvania, their wage index at the rural floor is now 92.1% versus 83.3% in the prior year. And what that did was it brought up a lot of hospitals in Pennsylvania up to that rural floor, and as is the case on a lot of these particular states. There was a handful of losers here, depending on what wages were being included in the rural floor calculation of those particular hospitals. If we flip over to the next slide, there's only about 4 states that had a negative impact from this. During the proposed rule, there was a few more states on here that kind of mitigated the negative impact by canceling some reclassifications that hospitals had in place to bring the rural floor back up. But all these states here had about a 1% negative impact from the new rules. Maryland, West Virginia, Kentucky, and Maine are the 4 losers statewide that saw decreases in their rural floor. Everybody else went up at least, or was about 0%. So for the most of this country, there's been some positive here, but there are a few hospitals, again, that wouldn't have gotten the rural floor that are negatively impacted too. On that stand front. So I'm going to take a pause here for another polling question so you can all get your CPE credits. Do you know in 24 if your hospital is being paid the rural floor or not for the first time? So historically, you may never have gotten paid the rural floor. After these new rule changes, is your hospital being paid the rural floor? A would be yes, B, no. C was paid the rural floor in the prior years. D, I'm not sure, or E is not applicable. So we'll give some time for some folks to answer those polling questions. It'll be up for a little bit there. All right, we're going to move ahead to talk a little bit about some capital changes here, capital reimbursement, more specifically capital dish. If we flip over, again, we're seeing CMS reacting to recent court decisions that providers have appealed over time. Historically, this really impacts those hospitals that are reclassified from urban to rural, and they're kind of a hot topic just because of the sheer volume of hospitals that have done this reclassification. Is that historically those hospitals that did this reclass lost the capital dish payment by going to rural with the bed size requirements. So hospitals are losing a few $100,000 a year with the way CMS was interpreting the rules at the time. Court decisions favored the providers in this, and now what CMS has done is they have agreed with the court in that they will no longer take those capital dish payments away from urban hospitals that are reclassified as rural. If we flip off to the next slide there. So starting on 10/1, those capital dish payments will come back into your claim payments. So you'll get them through your claim payments. And as usual, they'll get settled upon the cost report filing. Again, what we've seen is Medicare is taking a little bit of a strict stance here in that they're only going to apply it prospectively, even though the courts decide otherwise. So this is only going to be a prospective change with this final rule, meaning that if you are one of these hospitals that have been impacted, hopefully have been at least protesting this takeaway and appealing it, still recommend you pursue the appeal for prior years, given the court decision and Medicare's decision to take this off the table moving forward. Probably the likelihood of winning on appeal is a little bit higher than it normally would when you're appealing Medicare. So again, if you need any assistance there, your normal attorneys will handle most of the appeals, and if you need any recommendations, you could reach out to us. So I'm going to take a pause here before I go on to the next group. We'll talk about the poll results. So before I asked what if your hospital was getting paid the rural floor for the first time, 6% it was yes, 12% or no, 8% was always paid rural floor in the prior years, 30% are not sure, and then another 40% does not apply to your facility or entity. So moving on, I'm going to talk a little bit on Medicaid DISH, which is a federally funded program here, and some of the changes and items from a lobbying standpoint that hospitals need to be aware of in working with your government relation officers and local politicians here. So our expected cuts for Medicaid DISH funding from CMS down to each state. These pending cuts are estimated to be about $8 billion. These are the cuts that have been lingering around for about 13 years now after the Affordable Care Act. When that was put into place, the federal government was supposed to cut back funding to each state for Medicaid DISH programs because more people would be insured and ultimately uncompensated care costs would go down. As Keith mentioned before, the actuaries made a pretty significant adjustment to the uncompensated care pool in terms of covered individuals, meaning that you're getting less payments from that pool. This kind of gets tied hand in hand here. We don't know if this will get extended out. It has been delayed 13 times over the course of many years. There is an act out there that's pending approval that would delay it for another 2 years. But right now it's scheduled to go into place on October 1st. And typically the way it works is it depending on your state's fiscal year for the DISH program, the impact of such a large cut may have a different timeline than your fiscal year. But these cuts would be significant where some states would lose about 50% of their Medicaid DISH funding. That could significantly impact your hospital operations. So these would particularly be your lump sum payments that you get from your Medicaid program for DISH and treating that patient population. So we're not sure where this will go given federal spending and deficit. And at the same time, as David mentioned, the constraints hospitals had financially has been the worst year, or at least the last 2 years. So such cuts here could be pretty significant. So I'd recommend you touch base with each of your government relation officers to find out what the pulse is down in DC on this extension, because again, it's not going to just impact your hospital, but all the hospitals within your state and across the board here. So Next, I'll talk a little bit about the Medicaid DISH, so proposed rules that have been put out by CMS. This was in turn to recent legislation that was put out back in 2021, which changes how Medicare will allow states to calculate the upper payment limit. So each year, those Medicaid DISH payments that your facilities get are limited to your hospital-specific limit. And a lot of times what we've seen is the payments are made prospectively based on old data, about 2 to 3 years old data. And then you'll be audited either by the state or the state CPA firm who they contract with at the current year costs. And then we see hospitals are going above the upper payment limit. We're seeing it a lot in the last year or so with a lot of incremental supplemental payments that Medicaid has put into place as a result of COVID, increased rates, increased Medicaid expansion. So we're seeing a lot of hospitals get closer to their limit. And what Medicare has done here is said that they're only going to allow hospitals to include when the patient is Medicaid primary or had Medicaid managed care primary. If you remember, there's been an argument going back for years of whether or not the Medicare and Medicaid dual eligibles should be included in the upper payment limit. So those dual eligibles will be out of the calculation moving forward. Depending on your state fiscal year, it will depend when it goes into effect. There is a caveat that if you're a high outlier facility in the 97th percentile of SSI population, that they'll let you choose which option you can have. In that proposed rule, they go over a number of different methods of how they would calculate and publish that data. As you know, SSI data is pretty much a black box to begin with. So there is concern of what Medicare will provide hospitals to see if they qualify for that exception. If we move on to the next slide there, Keith. Yep. So this will just go a little bit more in detail. The other thing I do want to mention is there is a long lag between the state DISH audit results and when they come to recoup funds. Sometimes it's about a year from when they say you're over your upper payment limit and they come to recoup it. What this proposed rule also has opened the door is to allow the auditors greater discretion to make audit adjustments and recoup the funds on behalf of the state. And if that does finalize as proposed, that gives the auditors who are typically contracted third parties more discretion to make adjustments if you don't provide data, which could be very detrimental to your upper payment limit. So, keep an eye on some of the proposed rules with how Medicare wants to give more authority to the auditors on these on behalf of the state. So we know some states are pushing back on this particular piece because they want to maintain control of it, but please keep an eye on that. And the next slide, I'll give you an idea of when these new provisions would come into place. So even though this proposed rule is technically not final yet, the legislation has this going retroactive as of 10/1 of 21. So that would mean that if your state plan year is June 30, the first period in which these new rules would apply to the dual eligible would be your state fiscal year 23. All the other portions of the proposed rule will be 60 days after the final rule is published. They're still going through the comments and have not issued the final rule. So the issue where discretion to the auditors are given would be more immediate than some of the others here. So keep an eye on that because I know a lot of hospitals are going through those DISH audits as we speak today. We'll take a pause here for the next polling question. I believe this is our last polling question. So does your facility know the impact to your hospital's upper payment limit for these new regulations? A, yes. B, no. C, our hospital associations model it for us. D, our hospital does not receive Medicaid DISH payments. Or E, it's not applicable to your entity or organization. We'll give everybody a minute there to get their responses in. This is the last polling question here, and then we're going to move on and talk about outpatient changes here next. So we'll flip off to the next slide here. So we've been focusing a lot on the inpatient final rule. Back in the summer, Medicare issued the proposed rule for outpatient. And again, to similar points above, you have to be careful of who this also impacts besides your traditional Medicare patient population. This is a slide here that we put together that reconciles the conversion factor, which is basically your outpatient rate from 23 through 24. These changes, if finalized, would be effective 1/1/24. So you still have a couple of months. This is typically finalized in early October. So it only gives you a handful of months to prepare for the actual results and changes to go into place. Just like we spoke about earlier, Keith mentioning the market basket, the CMS is typically markets that you're going to get about a 2.8% increase. But with all these reductions that you see on the screen here, it comes out to be a bit lower in actual. So if we flip over to the next slide here, kind of give a high level. So the proposed payment increase is really 2.2% if you do the actual math, which is what you'll see out there in the Medicare publications, is that you're going to get a market basket increase of 3% less the productivity adjustment. So you'll see Medicare published out there that hospitals are getting at 2.8%, but that factor is before all the budget neutrality reductions that they take into place. So your actual payment increase, if you're just looking at the pure rates, only about 2.2% compared to your cost increase year over year, are far exceeding the 2.2. So again, this outpatient rule impacts not just your hospitals, but also the 6,000 ambulatory surgical centers that are out there. These rules are put out together. We're seeing some shift off OPPS into the physician fee schedule. A lot of dental changes here with the services. So we're not quite sure that impacts a lot of folks on the call today, but a lot of movement in dental services and codes with the outpatient rule being proposed. If we skip ahead there, the other change that we're seeing, and we saw it on the inpatient side a little bit that Keith mentioned before, with some of the behavioral health push towards an increase towards behavioral health coverage, increasing behavioral health payments. We're seeing this on the opposite side here on the outpatient as well, that they've increased payment coverage as well as rates regarding to behavioral health services, specifically intensive outpatient programs and partial hospital programs. So again, if your hospital is looking to expand behavioral health, we know there's a shortage in many areas across the country. And we've talked to a number of hospitals about expanding outpatient behavioral health. Medicare is starting to recognize that there needs to be a change in how these are being reimbursed and what Medicare is covering. So we will keep an eye on that. If you're looking to expand mental health, this proposed rule for outpatient could be significant, and depending on your Medicare population. Next, I'll skip over to the next slide, and there's only a couple of bullet points here, but there are some hospital price transparency rules that we want to make sure you're aware of, that we're working on getting some information out to folks. Is Medicare has put a lot of proposed changes in for hospital transparency. The big thing that I saw in there is that they are proposing to use a standard template to display your charges and contracted prices. Right now, hospitals are have their own formats. It's a lot of different information, different formats. People can't find the information. That could be pretty significant, given the tight turnaround that they would want hospitals to get this updated on your public websites. So Medicare is also tightening up the enforcement provisions on price transparency. Most notably, they're going to be a little bit more stricter with corrective action plans, with certain strict deadlines and penalties for failing to meet those corrective action plans timely. Now they've been given a lot of warnings and allowing hospitals kind of correct things on their own timeline. But what we see here with the proposed rules that this is going to get ratcheted down. Another thing that we don't have a bullet point here for that Medicare has proposed is that a link to the public charges must be displayed on your front web page. Meaning current state today, you have to go through a lot of clicks to find your standard charge file. Under the proposed rule, they're going to require hospitals to make sure it's on your front homepage, a separate link to get to it, which will make it easier for CMS and others to locate the file and audit it. The other thing with the standard template is it'll make it easier for Medicare to audit your compliance with that standard template. Right now, they're having difficulties, taking them a lot of time. So there won't be a lot of time to get up to speed if these get finalized. You should have discussions with your team on what lift it would take to meet the new requirements by January if this does get finalized. There could be a delay of implementation date, but the way things are trending, we would expect that some of these changes with price transparency are finalized as there's just been a heavy push on it. Keith spoke a little bit about prior about the inpatient quality reporting. There's been some increase in outpatient quality reporting metrics that they're looking for. Failure to report the outpatient metrics is a 2% reduction to your payments. So again, there's some new factors and items that they're looking for in terms of outpatient quality reporting that it's pretty much you report it or you get penalized versus where you have the value-based purchasing program where you're being measured. This is a kind of, you got to file it to make sure you don't get reduced. So please keep an eye, make sure that your quality departments have all the new potential requests in order in case these do get finalized. Make sure that you guys are compliant as quickly as possible on those. Next slide, I'll talk a little bit, we only got a couple minutes left, about the 340B drug payment policy remedy. So what Medicare did was they proposed a remedy through rulemaking to relieve hospitals that were reduced payments for purchasing drugs under the 340B program. So from 2018 through September of 22, hospitals that purchased 340B drugs had their reimbursement rates cut. If you remember, hospitals used to be paid average sales price plus 6%, and those that were 340B got cut to average sales price less 22.5%. So the remedy solution was good for those 340B hospitals in that they would get a lump sum payment back to the hospitals for those. It's supposed to include the cost sharing that Medicare beneficiaries would have otherwise owed. Medicare said they're not going to pay interest on that. But the negative side of this is it's got to be done in a budget neutral fashion. If you remember when these cuts first went into place, they reduced hospital payments for 340B and increased all other outpatient services. So now they're going to go back and reverse everything. And in a budget neutral fashion, what you'll see is there'll be a 0.5% reduction to your base rate factor for outpatient for the next 16 years, which would start somewhere January 1, 2025. So this would not start in 24, but if finalized would start the following calendar year, which is a significant cut when you're only getting 2.2% actually year over year. It's a 0.5 point reduction. It's not 0.5%. So, this would be pretty significant to the outpatient hospitals, especially those that are not in the 340B program that have no offset to these reductions. So your 340B hospitals will make out because they're getting a lump sum payment back, but the forward years, even for those hospitals, would be reduced outpatient payments. Those comments were due just the other day on the 11th. So we probably won't see a final rule come out here for the next couple of months as they get through the comments. But it's something to keep an eye on because your hospitals could have a significant impact, especially those that are not in the 340B program. That one more slide that will just make sure we get on your radar for your government relations folks is the Senate bill for the Rural Hospital Support Act. that would extend out some of the programs that are continuously have to be renewed. One of those being the Medicare dependent hospital, permanently extending out the low volume hospital program, and also establishing new base periods for sole community hospitals and Medicare dependent hospitals to be based on 2016 data. There's been some staleness to the last time that those rates have been rebased, and having a rebasing period of 2016 would help out a lot of sole community hospitals and a lot of Medicare dependent hospitals. So, this would positively impact hundreds of hospitals if passed. So, if you are a sole community Medicare dependent, you get low volume, I suggest you work with your government relations folks to help keep pressure on this particular bill to help you out. We're just about done here in time.
Hey, Brian, I think we, as a group, we ended up responding to most of the questions that hit, but there's one outstanding around the Medicaid dish payment decrease and whether that affects critical access hospitals. I don't think we touched on that. Can you comment on that?
Yeah, we didn't touch on it. So this will likely depend on each state and how they're going to handle any potential cuts in the federal funding to their state.
Mm-hmm.
So states have discretion on how they use and distribute those dish funds to their hospitals. So they could take a stance and cut everybody. They could take a different stance and protect your critical access hospitals and keep them whole at the expense of everybody else. So I think it's going to be a state by state issue, and how the state has their regulations written on how critical access hospitals are reimbursed. So it may depend on your state. If that person wants to reach out directly to either myself or Keith Hutchison, we can probably answer a little bit better depending on your state, where we think things may end up for that particular area. So
great.
Thanks, David.
Great.
Yeah. No, makes sense.
Yep.
Well, I think we're landing the plane right at the top of the hour, and I don't know, guys, if there's any other questions in the queue. I think like I said, we responded to most of them. So I think we're about ready to sign off. Keith H., anything else?
No, I appreciate everyone tuning in today. And if you think of something later, feel free to reach out to one of us.
Great. Thanks, everybody, for your attention today. Have a great day.
Thank you.
Thank you.